Good evening, everyone. This is Dr. Mangesh Deshpande, and we are talking about shoulder joint, one of the complicated joints, complex joints in our body. And we have seen different uh, diseases related to it, mainly intra-articular pathologies like avabahuk and sandhigata, extra-articular pathologies like Vishwachi, Khalli, Snayugata and Siragata. Systemic disorders like Amavat, Vatarakta, Asthikshaya and Asthimajjagata. And there are paratantra causes of shoulder joint pain. So, Avabahuk, Vishwachi, Khalli, Sandhigatavat, Amvat, Snayugatavat, Siragatavat, and Vatarakta. These are predominantly seen different disorders or clinical conditions which we come across when we treat shoulder joint pain in general practice. So, in these cases, we have come across one important disease, one important clinical condition. It is known as impingement of rotator cuff. So, rotator cuff impingement, it is very common lesion in general practice, in mainly in sports person, athletes, or in mainly in swimmers also. See, this lesion consists of rotator cuff tendons, mainly supraspinatus, then long head of biceps also, and that's it. It is related to coracoacromial ligament also. So you can see this in diagram. Transversing the gap between coracoid and acromial process is coracoacromial ligament, and this forms an arc or arch over humeral head. Below this arc runs supraspinatus tendon and intra-articular portion of tendon of long head of biceps. Between acromial process and supraspinatus tendon, there is subacromial bursa also. When arm is elevated, abducted, externally rotated, then supraspinatus tendon falls below or beneath coracoacromial arc and may get impinged against it. So, supraspinatus tendon falls below or beneath the coracoacromial arch and gets impinged. The clinical condition is known as impingement of rotator cuff. Why it happens? How it happens? When we should treat this condition? How we should treat this condition? The first point, the first important step of the pathology is chronic, often getting microtraumas. Repetitive use of arm and shoulder, mainly, visualize a traffic police who is repetitively using his shoulder joint and directing the traffic on roads. See, or you can see butterfly type of swimming, or that's it. In these cases, repetitive use of shoulder is done. In this case, it may result in microscopic damage to the tissues under coracoacromial arc. This leads to edema, hemorrhage. See, first impingement, first damage, chronic microtomas, damage to the tissues. Then this leads to edema plus hemorrhage with compromise in space available. Now, this vicious circle of impingement, comma, swelling, comma, muscles dysfunction, comma, again impingement, comma, again swelling, hemorrhage. This will create the problem. This will increase the pathology. And supraspinatus is the first important structure which is involved in impingement of rotator cuff. Because of chronic hemorrhage, we tell the patient to put ice into it. In case of in Sushrut Samhita also, Shita Parishek is written for these type of injuries. After chronic microtraumas, it tends to vascular impairment. See, if any vascular impairment leads to neurological impairment. Sira Graha leads to Sira Snayu Vishoshya. So we have to be very much alert in these type of pathologies. If it is vascular impairment, in sports, mainly in sports such as say swimming or in traffic police, particularly say in butterfly type of style of swimming, where swimmer is required to rotate the arm on the shoulder many times. So there may be interference with blood supply to that supraspinatus tendon, and this may result in localized area of say necrosis of supraspinatus tendon, and it may damage that particular area. It will lead to edema and inflammatory reactions. After chronic microtraumas, vascular impairment, the pathology goes towards partial tear of rotator cuff, mainly, of course, supraspinatus tendon only. And after that, again, previous trauma to acromion process or acromioclavicular joint can cause more impairment of say acromion process, and it reduces the space available under that arc. Damage to supraspinatus gets worsen, impingement gets worsen. The main symptoms One of the main symptoms is, of course, excruciating pain, and it is always uh, raised because of, say, some activities, say, uh, abduction, say abduction of arm, etc. When arm is whipped rapidly from external to internal rotation, say in case of badminton, or in case of butterfly type of swimming, pain is uh, raised, or pain gets elicited. It is usually localized, and it is superolateral uh, of shoulder joint, and it is just lateral or anterior to acromion process. Pain may be more diffuse also. Uh, if there are other tendons involved, like say long head of biceps, then, or generalized inflammatory response is there, then the pain is diffused and not a pinpoint pain. A snapping feeling or sensation may occur when arm is brought from external to internal rotation. Tenderness is there at that particular area. Pain when um, when arm is actively abducted between, say, 90 degree to 120 degree, then pain is there. Uh, then pain occurs. Impingement sign may be present, and atrophy of muscle may be there after few weeks. Biceps tendinitis may occur at that particular site. So these are some important things which are to be examined thoroughly, and we have to treat it accordingly. We have to treat the patient according to these signs and symptoms. Complete tear of rotator cuff. If it is partial, then it is okay. But it is like, say, impingement only. It is like impingement only. Complete tear are very rare, but may occur also. It is very rare below 30, but in chronic rheumatoid arthritis cases, complete tear of rotator cuff may be present. In that case, initiation of glenohumeral activity is absolutely absent. So that is very important, say, sign of complete tear of rotator cuff. Complete absence of initiation of glenohumeral activity. So in complete tear also, tenderness is present, pain is there, impingement signs are there, muscle wasting is there, and that's it. Patient may not be able to abduct the arm with minimum resistance also. So that is there. In these cases, X-rays are normal, and sonography will show the exact defect in this. But in today's era, today's world, we prefer MRI over sonography. So these are some important points related to impingement of rotator cuff. So just a minute. Now we are seeing AP view of shoulder. This is acromion. You can easily see this. This is end of, say, scapula. Posteriorly, you can see this. This is posterior view. Then this is known as coracoid process. This is glenoid cavity. This is scapular blade. This is humeral head. Humeral head. Anatomical neck. Surgical neck. The anatomical neck is anatomical division of head and shaft. Remember one thing, if patient has got fracture at anatomical level, anatomical neck level, then probability of avascular necrosis of head of humerus is much more than fracture at the site of surgical neck. So this is surgical neck, then this is acromioclavicular joint. This is greater tuberosity. Greater tuberosity is lateral side bulge. Clavicle. This is glenohumeral joint. So again, I would like to repeat, because mainly in Ayurvedic practice, only this AP view is very important and not other views. AP view is important. If we are treating the cases with the help of Ayurveda, then only these 3-4 points are very important. This is acromion. Posteriorly, you can see this. This is end of scapula. This is coracoid process, glenoid, scapular blade, humeral head, anatomical neck, surgical neck, acromioclavicular joint, greater tuberosity. This is lateral bulge. You can easily feel it. Greater tuberosity. Then this is clavicle. And this is glenohumeral joint. Humeral joint. So it is glenoid cavity and humerus. In between, it is glenohumeral joint. So this is very important, and this is the second view, and it is also known as Y view or lateral view. It is mainly Y view. You can see that Y. It is mainly related to, say, dislocations, scapular fractures, degenerative changes. You can easily locate it and you can easily treat it accordingly. So this is clavicle. This is acromion. This is coracoid process. This is humeral head. This is scapular body, and this is inferior angle. So first is clavicle, second one is acromion, third one is coracoid process, acromion, coracoid process, humeral head, humerus, then scapula, body of scapula, and inferior angle of scapula. So this is basic alignment of X-rays. You can see this on the screen. So these are important points to be remembered in case of shoulder joint. Then we can come to say other pathologies related to it. But before that, see, we have seen disorders of shoulders, mainly different type of arthritis, pyogenic, rheumatoid, tuberculosis, OA, frozen shoulder, then mechanical derangements, mainly different types of dislocations, mainly anterior recurrent dislocation is there, complete tear of tendinitis or tendinous or rotator cuff, painful arc syndrome, rupture of long tendon of biceps, and tenosynovitis of biceps also. We came across rheumatoid arthritis versus osteoarthritis. Bilaterally affected or rheumatoid arthritis plus wasting of deltoid plus flattening of shoulder contour is related to rheumatoid arthritis, and one joint is affected and asymmetrical loss of articular surface are the predominant points related to osteoarthritis in case of this. Flattening of shoulder contour, it is the resultant of axillary nerve injury, glenohumeral dislocations, and tuberculosis. So there are three important points related to it. Now, up till now, we are only talking about the diagnostic points of shoulder joint. Now, let us come to the clinical tests related to shoulder joint, the different clinical conditions. What are the different clinical tests related to it? So there are so many tests, but we will be coming across with main important tests only. So this is known as anterior instability test. Many a times, maximum times, when you are examining shoulder joint, you should be at the posterior side of patient. Examiner should be at the posterior side of the patient. So patient stand or sits, examiner is standing behind the patient, and he places one hand over that involved shoulder so that index finger is over humeral head and middle finger is over the coracoid process. So you can see this, how that doctor has placed his fingers. The thumb is placed over humeral head posteriorly. With other hand, examiner is grasping patient's wrist and abducts and externally rotating the shoulder. First index finger is at humeral head, then middle finger is over coracoid process, and thumb is over humeral head posteriorly. And the second hand with patient's wrist, he is abducting and externally rotating the shoulder joint. A positive test is one in which examiner's index finger which is palpating humeral head anteriorly, moves forward as patient shoulder is being abducted and externally rotated. It shows anterior instability of shoulder. Again, I'll tell you, positive test is how you can define positive test. Index finger, which is palpating humeral head anteriorly, moves forward as patient shoulder is being abducted and externally rotated. This is anterior instability of shoulder. So, anterior instability, after that, this is anterior drawer test. It is for knee joint also. It is mainly for many joints, that is ankle joint also. Now, patient is lying supine. Examiner is abducting patient's shoulder, say up to 80 or say up to 90 degree. Then you have to relax patient's arm and doctor will place patient's hand on involved side in examiner's axilla. Now he has placed his arm in examiner's axilla. Examiner will grasp patient's proximal humerus with one hand and forward flexes patient's shoulder to about say 20 degrees. Externally rotates it about 20 to 30 degrees. And with other hand, he is stabilizing patient's scapula. Now, examiner will push spine of scapula forward with index and middle finger of he will just push forward it and draws humerus anteriorly with other hand. Same like knee joint anterior drawer test. In case of positive test, patient shows apprehensions or a click is felt during the movement. Click is felt to examiner, click is felt to the patient also, and that indicates anterior instability of shoulder joint. Like that, posterior drawer test is also there, and along with that, anterior and posterior apprehension test is also there. Now, in case of posterior drawer test, see, you can see this. Examiner is grasping patient's forearm with one hand and he is flexing patient's elbow to about say 120 degree. Now he is abducting the shoulder to 120 degree, and then he is flexing it to say around 30 or 40 degrees. Now with another hand, doctor is stabilizing patient's scapula by placing index and middle finger on spine of scapula and thumb on coracoid process. Now, doctor will internally rotate the shoulder and will flex forward to around 90 degree, and he will push the head of humerus posteriorly. Positive test is one in which patient shows somewhat he opposes, which indicates, or he shows apprehension, which indicates posterior instability of shoulder joint. Posterior instability of shoulder joint is rare, and many a times you have to operate these in these type of clinical conditions. So if you think it is posterior instability, then remember you may have to operate these type of cases, which is very important. So don't do any experiment on it, and just uh, recommend it to an orthopedic surgeon. Supraspinatus tendinitis test. You can see this in this diagram. Easily you can see this. Examiner is holding patient's forearm and he is abducting patient's shoulder to horizontal position. Now, patient is instructed to abduct the arm. At the same time, examiner will apply some resistance to it. In this case, if pain is elicited over insertion of supraspinatus tendon, that means it is tendinitis of supraspinatus tendon. So, accordingly, you can treat these type of conditions. Supraspinatus tendinitis. In case of MT can test also can be done in case of supraspinatus tendinitis. Just raise your arm up to 90 degree with thumbs up position. Then instruct the patient to thumbs down, to instruct the patient to down his thumb, and at the same time, if patient gets pain at say insertion of supraspinatus level, then it is supraspinatus tendinitis. This is known as MT can test in clinic. Drop arm test, important test in again in clinical aspect. In this case, examiner abducts patient's shoulder to 90 degree. Now, while keeping the elbow fully extended. Now the patient will be instructed to slowly lower the arm to the side. Positive test is one in which arm drops to the side from a position of about say 90 degree abduction. It indicates rotator cuff tear, especially supraspinatus muscle. If patient is able to hold the arm in abduction, a gentle tap on forearm will cause the arm to fall on a particular side, and if there is a tear in rotator cuff, immediately arm will fall down only with a gentle tap. So drop arm test is important for supraspinatus muscle related pathology, rotator cuff impingement or rotator cuff tear in this case. After drop arm test, we can go for painful arc test. See how we should go for painful arc test. Examiner places a finger at inferior angle of scapula. Patient is then instructed to actively abduct the shoulder overhead. In this test, a positive test is one in which patient hides the shoulder and momentarily arm falters, usually at about 90 degrees of shoulder abduction, and then abducts smoothly. It indicates impingement syndrome, painful arc test. This is related to impingement syndrome. There are 5 diagnoses. You must be knowing now all the diagnoses which we yesterday we saw all the diagnosis related to it. Shall we? Should I tell you the diagnosis? Should I tell you the? Incomplete tear of supraspinatus, supraspinatus tendinitis, calcified deposit in supraspinatus, subacromial bursitis, and crack fracture of greater tuberosity. So these are some points which we should not forget. This is known as Dugas test. Patient is sitting in this position and now he is instructed to touch the opposite shoulder and then lower the shoulder onto the chest. In this case, a positive test is one in which pain is increased and patient is unable to lower the arm close to the body, which indicates impingement syndrome. In this case, patient gets severe pain because of impingement, mainly of supraspinatus. This is another important diagnosis, and it is absolutely clinical diagnosis. You need not have to go for USG of shoulder joint, that is ultrasound sonography of shoulder joint, or even not to go for MRI also. You can easily diagnose it with the help of your clinical assessment. Now patient sits, examiner stands behind the patient and with the index and middle finger of one hand applies pressure just below acromion process. In this case, a positive test is one in which localized pain or tenderness is increased. This indicates subacromial bursitis. So from behind you have to examine shoulder joint, that is number one, and with index and middle fingers of one hand you have to apply pressure just below acromion process. If you feel tenderness along with pain, then it is subacromial bursitis. For confirmation of bursitis, subacromial bursitis, there is one more test known as Taubman test. And again, I'll tell you, this is subacromial bursitis can be easily diagnosed at your clinic level. Patient is sitting, examiner stands behind, index and middle fingers of one hand applies pressure just below acromion, and if pain or tenderness is observed, then examiner hold patient's distal forearm and passively abducts patient's shoulder over 90 degrees and maintains pressure just below acromion process. Positive test is one in which pain and tenderness is decreased as shoulder reaches 90 degree of abduction. Pain is decreased as shoulder reaches 90 degree of abduction, which indicates subacromial bursitis. So, this is confirmatory test related to uh, uh, bursitis, subacromial bursitis. It also comes under impingement syndrome only. This is related to. This is also a very important test. Huh? This is related to say instability of long head of biceps tendon. In this case, patient sits or stands with elbow flexed to 90 degrees and forearm is pronated. Examiner will hold patient's flexed elbow in one hand while holding patient's wrist with other hand. Now, examiner doctor will supinate forearm while patient will resist the motion. He will apply the pressure, he will resist for that particular motion. In this case, positive test is one in which pain is elicited and biceps tendon pops out the bicipital groove, which indicates biceps tendinitis or instability of biceps tendon, mainly long head of biceps tendon. So it is the important test. So there are so many tests related to shoulder joint. Just I'll take one or two more tests. There are many tests. This is also related to biceps tendinitis only, or say rupture of biceps tendon only. In this case, now examiner is standing behind. He is clasping both hands on top of the head to support the weight of upper extremities. Now, patient is instructed to contract and relax biceps muscles. While patient does the contraction and relaxation of biceps, examiner will palpate biceps tendon. In this case, if you don't feel biceps tendon, that indicates rupture of long head of biceps tendon. It is always unilateral. You can easily compare it with the another, that is normal side, and you can easily diagnose the specific thing. So this is very important, and we come across these type of cases, but we cannot diagnose it properly because we don't know these simple clinical tests. So in this case also, patient is instructed to abduct the shoulder to 90 degree and flex the elbow to 90 degree. In this case, a distal bunching up of muscle occurs, which indicates rupture of long head of biceps muscle. I have seen these cases, and you also have seen these type of cases, but we ignore these type of clinical tests because we are not aware of these simple tests. Proximal bunching up of muscle indicates rupture of distal biceps brachii muscles. So it is related to rupture of biceps. So this is one important test. See, in this case, examiner is holding patient's arm in slight abduction and monitors his radial pulse. Now patient is instructed to take and hold a deep breath, extend the neck and turn the chin toward the side being tested. At the same time, examiner will externally rotate and extend patient's shoulder. Now, patient will be instructed to turn the head towards opposite side. In this case, radial pulse disappears. That indicates thoracic outlet syndrome or thoracic related some pathology. So we have to be very, very uh, uh, alert in these type of cases. This may be many a times this is vascular pathology, and one must do thorough examination afterwards. Go for all the investigations related to thoracic outlet syndrome. I think only one or two tests are there. See, I know these are some boring points, or you may think, is it really necessary in my clinical practice? The answer is yes. It is really, really necessary in your clinical practice, as many a times we come across these type of cases, but we do not understand what to do, and then we go on treating only Amsashosh, or we go on treating only Sandhigatavad or frozen shoulder. But no, there are so many different type of diagnosis which we should not ignore, and we can diagnose it only with the help of clinical tests. You need not have to go for say sonography, x-rays, or with MRIs also. Now you can see how patient stands. He is instructed to abduct his arms to 90 degree, externally rotate the shoulder and flex the elbow to 90 degrees. Now patient is instructed to open and close the hands slowly for at least for 3 to 4 minutes while maintaining this type of position. If patient is unable to maintain this starting position for 3 to 4 minutes, if he experiences pain, if he experiences heaviness in the arm, or if he experiences tingling or numbness in the hand, it is related to thoracic outlet syndrome. It is not related to shoulder joint pathology. It is thorax related. Some different pathology is there. So these are the important pathologies which we come across in our day-to-day clinical practice. Now there are many things related to Abhyanga, Svedan, Nasya, Snehapan, Siraved, and Marma Chikitsa. We definitely tomorrow we will come across all the clinical details related to it. But I'll go for mainly for say Abhyanga. In case of Abhyanga, Tailam Sankuchite Abhyango, Masha Saindhava Sadhitam, Bahu Shirshagate Vate, Nasyam Panam Cha Auttar Bhaktikam. It is written in Charak Chikitsastan 28. But I would like to tell you all that Nasya and Auttar Bhaktik Sneha will not immediately treat your shoulder joint pain patient, and you may feel depressed with this sutra. According to Acharya Sushrut, you have to treat the patient in shoulder joint pain. Immediately you go ahead with Snayugatavat or Vishwachi, and accordingly you treat the patient and you will get good results. But in shoulder joint pain patient, if you give only Nasya or Auttar Bhaktik Sneha for Panartha orally Auttar Bhaktik Sneha, then it will not reduce his pain immediately, and patient will not be satisfied with your clinical expertise. So, um, say if it is Abhyanga, go for a select mainly Masha Saindhava Sadhitam, Mahamash Tel, Ashwagandhadi Tel, Baladi Tel, Mashadi Tel can be used. Masha Kwath plus Lavana Kalka can be used for Abhyanga in these type of cases. Pinda Swed, Upanaho, Swed or Annalepan can be done in case of pain in shoulder joint, in case of say Avabahu or Vishwachi or other things. In case of Nastya, Mashatel for Bruhan, Gruta, Tela, Mausaras, etc. can be used as Nasya. Kalyanaka Gruta or Anutel can be used widely in case of shoulder joint pain. Karpasasthyadi tel Chhagaladya Gruta is used as Nasya in many cases. So you can use it. When it is Stamba, go for Bala Guduchadi as a drug of choice or Narayan, Vishagarbha or Dashamul Tel. In case of Shul, go for Erandasneha, Prasarani Tel or Indukanta Telam. In case of Kampa Pradhan Samprati, go ahead with Sahacharadi and orally think of Chhagaladya or Saraswat Gruta. So, in this way, we can treat Avabahuk or shoulder joint pain. In case of Snehapan, we use capsule Gandhatel as a drug of choice, Kalyanaka Gruta, Sukumar Gruta, Chhagaladya Gruta, Masha Tel can be used. We use Karaskar Gruta also in Shula Pradhan Samprapti along with Mausa Shosh, that is muscle wasting along with pain. In these cases, we use Karaskar Gruta as a drug of choice. So tomorrow we will come across with many different treatments, many different kalpa, yoga, and mainly panchakarma, peculiar panchakarma. Have we ever heard about Vamar in shoulder joint pain? In shoulder joint pain is Vatavyadhi only, but is it possible that we go ahead with Vidyakarma or Rakta Mokshan as a procedure of choice for pain as a painkiller? Tomorrow we will come across with all these things. Till then, it's good night and goodbye. If you have any doubts, you can ask me in chat box also, and we will be discussing these things. Dr. Gary sir, do you have any doubts? You can ask us. Dr. Swati madam, Dr. Naveen Upadhyay ji, if you have any doubts, please ask. Dr. Veda, I am very thankful to you all that at 11 o'clock in the late evening also you all people are joined and listening to this shoulder joint. Dr. Amit Kashid, Dr. Rajani Jadhav, 9820958421 is my mobile number. If you have any doubts also, or if you want to give me any instructions also, please definitely tell me about that, and I will definitely try to improve in this. Thank you, Shreyas E-Learning Academy, for giving me this opportunity. Thank you, Dr. Amit. Dr. Amit?
Yes, sir. Yes, sir.
Okay.
Okay,
Today, shall we stop for a while? Tomorrow, let us start with another topic related to Panchakarma and some medicines or combinations.
sure, sir. Sure. So, thank you, sir. Thank you on behalf of Shreyas E-Learning Academy and all delegates also. We thank you for sharing your this valuable experience. Thank you, sir.
Thank you. Thank you all. Good night.